ICL technology is fantastic for the correction of low to high myopia as well as astigmatism, but there's another subset of patients I think who can really benefit from that technology, and that's patients who have keratoconus. Patients who are seeking vision correction, but because of their keratoconus, whether that's form fruste, true keratoconus, pellucid marginal degeneration, they're just not good candidates for laser vision correction due to the risk of ectasia. They may be great candidates for ICL technology. So, Neda, what are some things you consider when a keratoconic is coming in and they're seeking refractive surgery?
Like any refractive surgical patient, it's important to prove stability of their refractive error. This is especially true for patients who have form fruste keratoconus or true keratoconus, because as we know, these conditions can be progressive. And so we spend a lot of time checking prior records, getting information. And one actually key factor that for me is reassuring is when I look at the refractive correction in their glasses, especially if the glasses are at least a year old, to see that there's stability from that to the current measurement gives me assurance. If the patient has shown progressive changes and we have documented evidence of progressive keratoconus, we then recommend collagen cross-linking first to stabilize the keratoconus and the resultant refractive error prior to considering then a lens-based procedure like the ICL.
Yeah, I think that's a really important point you bring up. If the patient has keratoconus, they have a progressive disease and there's evidence of progression, we want to make sure we're treating the disease first. The refractive correction can come later. What's most important is just treating the disease pathology, or at least stabilizing it or freezing it in its tracks. Once that refractive error has been stabilized, then ICL surgery is a great option because there's no reshaping of the cornea with a laser. So there's very, very low risk of inducing ectasia with ICL technology. Probably the only thing unique in these scenarios for these patients is I'll often counsel patients, because ICL surgery is being done based off of their refraction, depending on the amount of inferior steepening, the size of their cone, whether or not their cornea is central multifocality, the end result, there may be a little bit of a refractive surprise. So especially if these patients are high myopes, they're going to be thrilled with their vision after ICL surgery, but I often will counsel these keratoconic patients. There may be a little bit of variability in how they heal after surgery.
The vision a keratoconic patient would get with an ICL mimics more the vision that they have with glasses than with contact lenses, especially if the contact lenses are gas-permeable contact lenses or scleral lenses. So the way we counsel patients when they come in for the consideration of ICL in the setting of keratoconus is if they prefer their vision with gas-permeable contact lenses or sclerals over their glasses, ICL is not a good option for them. But if a patient has keratoconus and their central topography, for example, is mostly bow tie in shape, and that the central topo then matches the refractive cylinder, refractive astigmatism, and they tell us they're reasonably happy with their glasses and they have stable keratoconus, that patient can do very well with the ICL and they can have fantastic results.
Yeah, and the great thing about the ICL technology is even for these keratoconic patients, the post-operative care remains the same. And so these are not patients who necessarily have a more prolonged healing course than an otherwise non-keratoconic patient. They get that same level of refractive correction with the same post-operative course.
And given that ICL can correct up to -16, it really is a life-changing opportunity for these patients who can have great vision without spectacles or contacts.